Your neuropathy doesn't follow the rules. Maybe it came on suddenly. Maybe it's in a strange band-like pattern, or one side of your body. Maybe it followed a flu-like illness, a rash, or a tick bite you barely remember. When nerve pain behaves unusually, there is a category of cause that conventional workups frequently miss: infection. Certain pathogens are masters of hiding inside the nervous system, residing in the nerve roots themselves and igniting them from within. Pain is a signal, and sometimes that signal is the immune system fighting an enemy hidden inside your own nerves. Today we examine infectious causes of neuropathy, focusing on two very different but illustrative invaders: the bacterium behind Lyme disease and the virus behind shingles. Both teach us how an infection can take up residence in nerve tissue and cause lasting damage. The first mechanism is direct invasion of nerve tissue. In Lyme disease, the spiral-shaped bacterium Borrelia burgdorferi, transmitted by tick bite, has a remarkable ability to spread into the nervous system. There it can inflame the nerve roots, producing a painful condition called Lyme radiculoneuritis, in Europe often called Banworth syndrome, with severe radiating pain. And it can cause cranial nerve problems such as facial palsy. The infection physically and chemically irritates the nerve, producing pain, weakness, and sensory disturbance. The second mechanism is the most cunning: latency. The varicella zoster virus, the virus that causes chickenpox, never fully leaves the body after childhood infection. It retreats and lies dormant for decades inside your sensory nerve cell bodies, clustered in the dorsal root ganglia along the spine and in the cranial nerves. When your immune surveillance weakens through age, stress, illness, or immune suppression, the virus reactivates. The virus reactivates, travels back down the nerve, and erupts as shingles, the classic painful band-like rash following the exact territory of a single nerve. The critical part for neuropathy is what the virus does to the nerve on its way out. The reactivation inflames and damages the nerve and its ganglion. In many patients, especially older adults, this leaves behind postherpetic neuralgia, a relentless burning, stabbing, or electric pain in the affected area. That can persist for months or years after the rash is long gone because the nerve itself was injured. The third mechanism is immune-mediated. Sometimes the lasting damage is caused less by the pathogen directly and more by the immune response it provokes. As we saw with gluten, molecular mimicry can occur. Antibodies generated against an infection can cross-react with nerve components. Other chronic infections, including certain viral hepatitis infections, which can trigger an immune complex disorder called cryoglobulinemia, as well as HIV and others, damage nerves substantially through this kind of immune crossfire and inflammation. Centrally, these infections can reach the brain and spinal cord. Neurologic Lyme can cause meningitis, cognitive difficulties, and inflammation of the central nervous system. Zoster can, less commonly, cause inflammation of the brain or its blood vessels. The cognitive fog, headaches, and fatigue that often accompany these infections reflect genuine central involvement, not imagination. In the peripheral nervous system, infectious neuropathies often break the usual symmetric pattern. They can be asymmetric, focal, or follow the territory of specific nerve roots. A band of pain around the trunk, a single limb, a facial palsy. This focal or radicular pattern, particularly when it follows an illness, a rash, or known exposure, is an important clue that points toward an infectious origin rather than a diffuse metabolic one. Now, I must be especially careful and honest here because this topic is a minefield. On one side, chronic Lyme has become a controversial label, under which some patients are subjected to months or years of unnecessary, risky long-term antibiotics, sometimes by practitioners exploiting desperation. Genuine harm has come from this. On the other side, mainstream medicine sometimes dismisses real, persistent post-infectious symptoms too readily, leaving suffering patients unheard. The responsible path holds both truths. Infections are a real and treatable cause of neuropathy, and they must be diagnosed with objective testing and treated according to sound evidence, not ideology and not denial. If Lyme is suspected, standard testing follows a validated two-step antibody approach, interpreted in the context of your exposure history and symptoms. Shingles and postherpetic neuralgia are usually clinical diagnoses based on the characteristic rash and pain pattern. Depending on the picture, your physician may test for other infectious contributors such as hepatitis viruses or HIV. And prevention matters enormously. The modern shingles vaccine is highly effective and is one of the best tools we have to prevent postherpetic neuralgia in the first place. At Regenerve, once any active infection has been properly treated, our role is to repair the nerve damage left behind and control the often severe pain. For localized postherpetic neuralgia, We use high-concentration topical capsaicin patches, which desensitize the overactive pain receptors in the affected skin, and targeted peripheral nerve stimulation to interrupt the pain signal. We add cannabinoid-based therapies and PEA to modulate neuroinflammation and neuropathic pain, and infrared light therapy and intravenous glutathione to support healing and reduce oxidative stress. Through telehealth and remote patient monitoring, we track your recovery and adjust the plan as the nerve heals. When nerve pain breaks the usual rules, look for the hidden invader, because an infection that is found can be treated, and the nerve it injured can be helped to heal. Don't accept unexplained when the explanation may be hiding in your nerve roots. If this gave you a new direction, share it with someone whose pain has never added up. Visit regenerve.com or text 314-88-65902. I am Dr. Padda, and I will see you in our next deep dive.